outcome in cases of orbital abscesses.
Good afternoon, everyone. I'm Dr. MELINA Mascarenhas. I'm going to present on etiology, management, outcome, and orbital abscess. Introduction: the orbital abscess is a serious infective condition of the orbit formed in stage 3-4 of orbital infections based on the Chandler's classification. It is most likely seen in adults and unlikely in pediatric age groups where we see orbital cellulitis. If left untreated, the orbital abscess will lead to severe ocular and systemic morbidity. The aim of the study to evaluate the causative agents and outcome in orbital abscess. The materials and methods used: it was a retrospective analysis of 16 patients that presented to the tertiary care center with orbital abscess treated over the past 3 years from 2016 to 2019. The data obtained include the age, gender, duration of symptoms, primary source of infection, visual acuity, pupillary response, the extraocular movements, the CT scan findings, culture sensitivity reports, antibiotic administered, surgical procedure done, visual outcomes, and complications. Clinically, clinical workup was done, examination was done, then we started them on broad spectrum IV antibiotics, CT scan, surgical drainage within the first 2 days, culture sensitivity reports were followed up, and daily monitoring. This is a patient with the right orbital abscess, but on the CT scan we can see that in the medially he has a medial wall of the orbit. We can see a subperiosteal abscess with the globe tenting and proptosis of the globe. The study includes 16 patients aged between 4 months baby to a 60-year-old man, mean age of 43 years. 63% of them were males. At the time of presentation, the duration of symptoms ranged from within 2 to 7 days in 15 patients, while there was one patient who came to us after 10 days. The results: the visual acuity was between 660 in about 88% and no light perception in 6%. In the infant, visual acuity could not be assessed. Some of the patients were too ill to respond to Snell's visual acuity testing at presentation. Relative afferent pupillary defect was detected in 38%. The ocular fundus was normal in about 81% who had clear media, while 13% it was not visualized due to corneal haze secondary to exposure keratitis. In one patient, there was central retinal artery occlusion. Extraocular movement restriction was seen in 38%. The source of infection: mostly we saw 63% in sinusitis, 25% dacrocystitis, 6% was because of furuncle on the face, and 6% was because of sepsis. The causative organism: most common was 31% Staphylococcus aureus, 6% Proteus mirabilis, 6% Burkholderia cepaceae, 6% alpha hemolytic streptococci, and 50% were culture negative. The location of the abscess was with the help of a CT scan. Among all the 16 patients who had the orbital abscess, 10 of them had also had sinusitis, like ethmoid sinusitis and maxillary sinusitis. Those with sinusitis underwent, along with the orbitotomy, FES surgery, and the culture, the pus sample was both taken from the sinus as well as from the orbital abscess, and then they were correlated. Among them, out of the 10, 9 of them, the organism grew. The similar organism was grown in both the sinus as well as the orbital abscess. After reviewing the culture sensitive reports, appropriate antibiotics were started. At the time of discharge, 6 of 16% had good visual recovery, no residual proptosis, no extraocular movement restriction, and no neurological deficits. 50% had a visual acuity of ranging from 6/18 to 660. One patient with no light perception at presentation had no improvement in visual acuity. There was no mortality in these series. Conclusion: early institution of appropriate diagnostic imaging and aggressive medical and surgical treatment